Thank you very much. So the presentation I'm giving today is really one on behalf of our team that worked on our regional project that we're hopefully going to share some of those experiences with you. And as you can see, it was a multidisciplinary team. We endeavoured to bring in the community through the representation of Dr. Mel Bates, general practitioner. Cecilia will be presenting later in the day on her perspective of some of the project. And we had cardiology involvement through also Dr. Niall Mahan and Jim O'Neill. And very much supported by our division of nursing within the Mater Hospital and the Irish Hospice Foundation. So the idea for today really is coming together in that collaboration, taking a stock of where we've come so far and hopefully re-energising the process in terms of moving towards the future, and very much addressing, as Norma has alluded to, the fact that although we have made progress, there is still a lot of work to be done. So the extending access study was born of the Irish Hospice Foundation's work to try and stimulate a little bit of progress in the movement of integrating palliative care in the management of non-malignant conditions. And we received a practice development grant from the Irish Hospice Foundation, the Irish Heart Foundation, and Baxter. And the idea of the project was, as a regional centre, how could we begin to join up our thinking and move from, I suppose anecdotal anecdotal reports of ways that we might work together to try and do something a little bit more planned and hopefully have a little bit of evaluation built in so that we could share our learning with others. So the team, which was Connolly, the Mater Hospital, and St. Francis Hospice, came together with the very simple question, but challenging in scope, of how best would we devise, implement and evaluate palliative care responses for patients with heart failure and their families in North Dublin. And we did draw from the learning that Norma has outlined, the fact that palliative care is everybody's business. And what we would say is that generalist and specialist practice are two sides of the one coin. So if you like, the palliative care approach needs to be embedded through the healthcare service. Every person in healthcare provision has a responsibility for recognising the needs of patients who are living with chronic conditions and perhaps entering a phase of end-of-life care. And that the parts of the healthcare system may well be specialist in their own areas of practice, whether that be cardiologists, geriatricians and so on, but they will all or should all have those basic palliative care approach skills. And as Norma has eloquently pointed out, having that level of palliative care approach skills shouldn't be underestimated. That in combination with one's own specialist practice actually can do a huge amount to meet the palliative care needs of a vast majority of the population. However, we have to get a way of systematically embedding that palliative care approach so that the standard of palliative care approach is equal across the country, so that there isn't a postcode lottery whereby a patient will go into, say, a cardiology service and some will be very person-centred and have very good palliative care approach skills, and others may be less focused on that. And then the other piece of the jigsaw puzzle is how do specialist palliative care practitioners then best support the palliative care approach skills? When is it right for us to provide indirect support through education, teaching involvement in quality improvement activities, and when is it right for us to become more directly involved in shared care? So these were the kind of questions that we progressed a little bit of thinking on, but I would say by no means did we solve the puzzle, and hopefully Fliss then will be able to bring a little bit of learning in the final session as to where things have moved following our project. So as I say, ours was a practice development project, or a quality improvement project, if you like, but because we were trying to capture learning in some way, we did do it through a framework of an action research process. And the idea of action research is it's not research in the sense of experimenting on people. It's more that collaborative approach whereby you are co-creating knowledge and sharing that learning. And the 4 stages of the Action Research Project have many similarities to the Plan, Do, Study, Act cycles that I think people are becoming more familiar with as quality improvement methodology is getting more embedded in day-to-day service delivery. But I'll just bring you through the stages that we went through, because I think if anybody is looking to perhaps develop palliative care within their own services, or incorporate cardiology and management of heart failure within their palliative care services, it is a useful place to begin. And the first two stages are the preparatory stages, and you cannot underestimate the importance of that. You know, those who do not plan will ultimately fail. And the thing about this is, many of these quality improvement projects are born of local passion and enthusiasm, and you know, people just want to get in there and start doing things, and it's about harnessing and holding that energy and putting a little bit of planning and understanding in, so that really you will get the maximum value for your efforts. So the first step is just understanding the situation. So, you know, draw from the best practice knowledge out there, review the literature, understand what has done, what worked well in other settings, because you don't want to be in a situation of completely reinventing the wheel, but recognizing that, you know, you have to have transferability. So not everything will be an off-the-shelf fit that you take externally and you bring in internally. So understanding the situation from a best practice perspective, but then very importantly, understanding the setting of your own practice. So what are the contextual, the cultural issues that apply in your setting, because you are delivering change in your own setting. And then having a little bit of space to plan and think about it, you know, articulate what is it you're going to do, how you're going to do it, and very importantly, how are you going to track the impact of what you've done in terms of outcomes. And we'll talk a little bit about that, because what we don't do very well is actually measure as we go along in terms of understanding what the impact is. And that's of critical importance, because in order to gain sustainability and long-term support, you have to be able to demonstrate the value of what you do in today's world. Having, you know, a good story and enthusiasm will not give you sustainable long-term funding. And very importantly, you can be biased yourself, you know, in terms of either overestimating the value of what you do and going down the wrong track, or very often underestimating the value of what you're doing and not capturing that. And then you move on to the exciting phase of taking actions, getting in there, and then the piece around evaluating actions. And although this is set out as a very linear kind of a process, it actually is quite circular spiral, you know, as you're going along, and you could have multiple little cycles of activity running concurrently as you're doing different change initiatives. So we did try and follow this methodology. So we did do a literature review initially, just to try and understand what was out there. And at that time, at the start of the project, there wasn't a huge amount of description of actual quality improvement projects to draw from. We did a survey of our staff in the sites to gain that baseline understanding of where they were at, and we also importantly did a number of focus groups with staff with both the hospital and hospice settings to understand perspectives and see how we might move things forward. And we just did a small selection of chart review of patients who had died to try and understand the care that was given. So I'm just going to give a little bit of a flavour of the results. More can be available on request. All of our tools can be shared, and I think in the packs as well you do have a report going into some of the more detail. But it was interesting, I suppose, at the time when we looked at the hospital setting, the cardiology setting, only 1% actually had received any formal training in palliative care in the 2 years. And there wasn't a huge amount of on-the-job teaching, you know, that focused on palliative care. And that did have a bearing then on clinical practice, because we asked people what they understood by palliative care, and we asked people to identify the principles of palliative care. And the principles of palliative care being about a focus on quality of life, achieving a good death, looking at a holistic approach to symptom management, caring for family as well as patients, extending care into bereavement, working as part of a multidisciplinary team, providing care in the place of the patient's choice, so having a flexible service that can move where the patient is and not expecting to come in. So any of those principles. And we actually found that, you know, nearly 70% of people really didn't have any understanding of those core components, and those are fundamental to a palliative care approach. But on the positive side, what we found was that of those people who had an interaction with specialist palliative care team, it had been a positive interaction. And that's important, because as specialist palliative care practitioners, we need to be very careful in our engagement with our generalist colleagues who may be specialists in other ways, that we are not either disenfranchising them, disempowering them. We're not, so we need to make sure that we're working in a way that is of help to them, because basically that is what we are there to do, to work in partnership. However, in keeping, I think, with the mission and the philosophy of the hospitals, 80% of people really did regard this as an important and rewarding component of work. And I think that's a very positive message to staff and to managers in these days of pressure, resource constraints. Actually caring for those most vulnerable among us can actually be the bit that gets us out of bed in the morning, But interestingly, looking at that 20%, so 1 in 5 people actually do not find it a rewarding part of their job. Now, whether that, we didn't go into the reasons, but whether that be for reasons of stress or feeling insecure or not competent to do so, but that's, it's an important number to look at. Again, interestingly, again, something for us just to reflect in our practice. We're all becoming more technical. It's about how you do, the things that you do rather than necessarily the way that you provide care. So there's a big mismatch. Nearly 90% of people felt that they could manage a syringe driver, and yet nearly a half felt that they had difficulty or they were inadequate in their communications with patients. So no huge surprises, but important for us to remember. So as I say, the misconceptions about palliative care was that an awful lot of people really regarded palliative care as end-of-life care. And when they were talking about end-of-life care in terms of any conceptualization, it was care of the actively dying patient. So it was the last days or at best weeks of life. And only 1 in 5 really would have thought about palliative care as being about improving quality of life, which has a huge knock-on effect, because that means they're not going to ask us to see patients if they need them, or they may not see the relevance of incorporating some of the palliative care aspects of care management into somebody's plan of care. Just again, perhaps no surprise, maybe positive, 50%, 51% did get support after the death of the patient, but an awful lot of people are managing these potentially stressful events with little in the way of debriefing or support. But again, very positively, a huge interest in furthering their practice. And the focus group's findings really just pulled out some of these things in more detail. So as I say, people actually did recognise the benefits of palliative care, but when they recognised the benefits, it was very much in a conceptual end-of-life care kind of a phase. So they said, we want patients to have dignity, to have symptom control towards the end of life. Very importantly and interestingly, it was strongly identified families appeared to have unmet needs, so they really wanted to extend the care to encompass families at that time. But the lens was all around end-of-life care. There was very little upstream. And we asked people, so what would they like us to see doing within the project? And what they wanted was a little bit of understanding of how the generalist specialist palliative care heart failure piece worked, who did what, a little bit obviously guidelines, algorithms to support their own practice, because there was a desire to improve one's own practice and not to hand it over to the specialist palliative care practitioners. A big focus around communication, prognosis, treatment options. Again, interestingly, the piece around communicating with families as well as the patient. And as the debate, evolved in the focus groups, people then began to say, well, maybe we might be better off having it involved a little bit earlier. How do we do that? And then the threats, which were very important to recognise, were those of resource constraints, which unfortunately only got worse over the time period of the project and afterwards. Because as you can see, the bits that people are identifying as deficiencies in care around communications are the pieces that are time and resource intensive. And then there was very interestingly highlighted the idea that the public perception was still as palliative care being for terminal care or cancer, and would that be a barrier? And Norma pointed to the fact in terms of her slide around where specialist palliative care services providing access to patients with non-cancer. And there's a certain amount of tick boxing at that time that people would say, oh, we do take on patients, but we perhaps don't actively go looking for them or letting people know that they can avail of services. And by all figures, 14% of patients with non-malignant disease accessing the hospice is suboptimal. And American figures would certainly be much more at about the 50% of patients perhaps having, we should be a little bit more balanced. So we then moved into our planning actions. They evolved out of those pieces, and we decided we'd look at the 4 domains. We were going to do some cycles around education, some cycles around communication, some around partnership activities, and some maybe around the organisation or the construct of how we deliver the services. And I will run through these because some of these may resonate with you, and if you are looking to bring something back to base and decide what's our little quality improvement project, these might be some things that you might do. So doing the survey was useful. It gave us an insight, but what we actually did was that we brought that information back then to the respondents, just in one-to-one teaching, just brought it back. We didn't say this is your response, by the way, or anything else like that, but we said just generally, we found that people didn't understand what palliative care is. Actually, this is what palliative care is, or, different things like that. We then really made that a focus in terms of the practice of the specialist palliative care team, was that we did an awful lot. We tried to do as much case-based learning as we possibly could in our normal practice of consultations, which we would do anyway. We try and have the teaching moments as part of the consultations, but again, in a busy service, sometimes it is easy to go in and talk to the patient and not necessarily always have, the nurse who's delivering the care in at the bedside with you, or the student nurse, or the NCHDs. So really went all out in trying just to draw it in. And I think, as Cecilia said, later on we also did joint consultations in any referrals. And I think some of that bedside shared learning, experiential, that really is relevant to the care of a patient, it gives it far more of a eureka moment where people can really understand. We did some local study days where we brought the GPs in around palliative care and heart failure, and the hospice and the cardiology service. That was a little bit more difficult in terms of resources. It takes a lot to put a conference on, so it wouldn't necessarily be the first thing that I'd be doing. And actually, I do think that the case-based teaching and learning the teachable moments have huge impact. What we did do was reciprocal education, because again, resources were constrained, people weren't being released for study days. So actually, the St. Francis has an education department, the Mater has an education department. We actually did a bit of a trade-off. You can come to our communication skills training for a day for free. You can come to an update day. And actually, some of the nurses from St. Francis came into CCU, and it just were shown around, updated a little bit, had an opportunity to talk, and vice versa. And that worked well. And the advantage to that is it actually starts building up the relationships, the networks of practice, in a way that going to a formal study day doesn't always do. And then we presented at conferences to learn, and we developed some online learning that we put on the St. Francis Hospice website, but actually that now has been supplanted by the All Ireland Hospice and the All Ireland Institute of Hospice and Palliative Care learning platform. So you'll see we're doing a few little cartoons as snippets of learning moments, but so you'll see the links as how to access the learning hub. But if you go into the All Ireland Institute Hospice website, www.AIIHPC.org, you will find the learning platform, and Kathy will give a little bit more detail, I'm sure. And on those e-learning, as we say, we're going to put this conference online, but there's a number of free learning resources there on symptom management, communication, and needs assessment that, again, are of relevance to people and something that your own services can access. So I would very much direct you in there. Around the communication activities, this was actually a very interesting early one that we did that surfaced a lot. And what we said was that we would just, because it had been identified that perceptions of palliative care would be a barrier, public understanding, we said, well, how about having a poster and a patient information leaflet just explaining what heart failure and palliative care is. And again, it shows about the importance of planning. What we said was that we would sense check the wording of the poster with both patients and carers and staff. And the interesting thing was, when we went and sense checked with staff, we got an awful lot of feedback from the ground. Don't think you can use the word palliative care. So we were like, well, it's a poster about raising awareness about palliative care. What would you expect? Well, I don't think we should use the word. And, do we have to directly really say, that somebody might not be getting well, planning for the future, things like that? So that was really interesting, because when we brought it to the patients and the family members, they were like, we want to hear more about this. We have no problem. So it was a very powerful change management tool, because we were actually able to go back to the clinicians who were only acting out of the best interest, because they really did have a perception that, perhaps this would be destabilizing or difficult to patients. And we were able to say people do want to hear this. So they said, okay, so we believe the patients, the families, and Cecilia put it up on her wall in her heart failure review clinic as a very clear, which I think is there still to this day, and the patient information leaflet. So again, it's just our wording around what palliative care is, but again, it's getting those principles there that in most circumstances the cardiology team, the general practitioner will be able to deliver a lot of palliative care, but if you need a more intensive form of support, is what we've said, that will help you look at quality of life issues and so on, then we're certainly there. And that piece around when should I receive palliative care, we explicitly said many people mistakenly believe that you can only receive palliative care when other treatments are not possible. Actually, palliative care can be provided to people of any age and any stage of their illness, and you and your healthcare team are the best people to know when palliative care is right for you. And if it hasn't been discussed, then feel free to bring it up yourself. So that was it. So I do actually think that that's a relatively simple thing to do. It's not hugely time intensive. The advantage, as I just would like to point out, is as much about the process. So it's not necessarily completely downloading an outside poster and put it up on the wall. It's about the process of engagement, discussion, surfacing anxieties about terminology. But that's there as a starting point if anyone wants to adapt, because there is a little bit about local ownership is good for things. So looking at partnership activities, we tried to build and develop those new relationships through the reciprocal education, through just meeting each other. So many people hadn't been out to the hospice to know what it was. How do you talk about perhaps community palliative care or a specialist palliative care admission to the unit or day hospice if actually you haven't seen the services? And people are much more comfortable when they've seen that. We obviously had our regular project meetings as part of the process. And also one that we found was interesting because we did have the care of a patient with a left ventricular assist device who unfortunately had received the LVAD as a bridge to transplant, but had developed a number of complications that meant that a transplant was not going to be possible. And it was an interesting perspective because at that stage at time it was deemed that his care was too complex to manage outside the cardiothoracic high intensity unit, and yet and that he couldn't be monitored on the ward. And yet with a little bit of discussion as we worked through, we actually managed to transfer the person to the hospice. So it just showed a little bit about the capability for management, and that was obviously around understanding what was the role of the LVAD, and it had come to a point where I suppose there wasn't active management and adjustment of the device. So actually it was possible to manage a very complex device in a specialist palliative care setting. But it does enter into a whole new domain around management of the device towards the end of life and switching off and all of that, which was certainly challenging. And what we again, it's that piece about networking. Bert Gordon is an ethicist who works in DCU, who would have worked with Regina McQuillan, my colleague in St. Francis Hospice, and actually bringing in an ethicist after. Now you could do it proactively or afterwards. We had worked through the whole ethical framework of how we were going to manage this, but we actually brought him in then afterwards because we just felt there was a good learning and reflection, and again it was that external piece around partnership. The great thing about Ireland is that everybody knows everybody, and there's people are happy to help oftentimes, but we don't often admit to putting the hand up and kind of saying, do you know what, we'd like a little bit of a discussion around that. So we published a paper on the management of that, which is in BMJ, Supportive and Palliative Care. Moving on to the organisational activities. So this is kind of the service delivery piece. So for us, we did actually recognise that we hadn't really been admitting patients with heart failure to our specialist palliative care unit, either for symptom control or for end-of-life care. So we looked at what were the barriers to that admission, and we broke those down, and we did successfully transfer people. And some of it were things like, again, if somebody was on inotropes, if you had to say you can't be on inotropes to come over to the specialist palliative care unit, then how are you going to transfer people? So again, it's a little bit like we're used to diabetics and sliding scales in the hospice. You do a modified sliding scale, you manage it in the context. So again, managing inotropes was actually relatively simple, because a piece had come to, we weren't escalating according to symptom control, because for those patients actually the inotropes were not contributing meaningfully to their management. But if they had been weaned down further or stopped, then obviously they would have deteriorated. So it was managing. So it is possible to manage inotropes without technologies and everything around, as long as you're selecting the right patients in the right framework of management. But that's the high end stuff. I mean, things can be much more straightforward as well. Very importantly, which I think was one of the biggest successes of the project, was meeting the needs perhaps of those patients at a slightly earlier stage of their illness, not the end-of-life care piece. And it's maybe slightly ahead of Norma's piece around where we need to do outreach services into the community, but perhaps patients that needed a therapeutic re-enablement rehabilitation approach to heart failure management to impact on their quality of life, that weren't fit enough to engage with the rehabilitation programs as were traditionally run within the heart failure program piece. And also what we did was we worked around needs assessment. We piloted a systematic needs assessment document, which very interestingly we found was complete failure. It was the palliative care needs assessment tool from Australia. And I think Cecilia may mention a little bit further, but Pauline will pick it up in her talk about patient-reported outcome measures, as this is where the direction of travel has moved to, and also our palliative care needs assessment document, which has now been produced by the programme, which is now something that we would hope will occupy this space, and you're going to get a talk on that later. And I'm just going to mention the competence framework has referenced, but the very important, the design and dignity program, and that's something that still is running. So it is something that your local organisations can avail of, make an application to the grant program, and having family rooms where there's quiet space where people can receive care, you can have family meetings with the patients. It just is an invaluable addition to care provision in an acute hospital setting. Just going to put in a very quick perspective just for some of the specialists. People want to say, well, what you moved into providing palliative care for heart failure. Our expertise is around oncology. How much is transferable? Quite a lot, really. The principles of symptom management are very similar. Just the things to keep an eye out for, don't use nonsteroidals and dexamethasone in the same way as you might in the cancer population. Remember that renal impairment is often present, and actually we do more systematically. We look at EGFRs, and we would consider in patients who have EGFRs less than 30, considering fentanyl or alfentanyl or buprenorphine as a first-line opioid as opposed to morphine. Dyspnea do use your same principles of opioid titration as per the cancer pain, but you start low and you go slower, so I wouldn't necessarily be titrating every couple of days. And remember things about the use for CPAP, and potentially also the fact that depression is a very significant symptom burden. So just in terms of evaluating actions, what you'll see is we looked then at the care of 22 patients who died over that time period, and what we found was that we were getting earlier referrals up to 158 days before death. Family meetings, their processes of care were improving. Place of death was still predominantly hospital, however it was beginning to move to hospice, and the decision making around ICDs very much was senior decision making, and we were prescribing medications oral and subcutaneous as is needed. But some of the learning really came out through the focus groups. There was that piece about significantly people felt that attitudes had changed. There's no shame in palliative care. Before it was like a death wish, now we see it as being about comfort, and sometimes it doesn't mean the end, which was very positive. But the pieces that the positives were the awareness of changes. It did have an impact. Communication had improved, networking had improved, and the organisation of care had improved. But we weren't fully there yet. There was ongoing needs for sustainable training, an increased need for medical engagement. The recognition that the psychosocial needs was the piece of the jigsaw that hadn't been met so well, and we'd made progress, but we needed to keep focus on that, and that really we hadn't begun to touch the community setting. So in my last two slides, I will just say is the lessons we would learn, which we would say if we were going forward. Do think about your capacity and your organisational capacity, before engaging on a change project. That's not to say you don't do it. With local enthusiasm, of course you can. But if you talk to managers and try and get people to understand that this is a little bit of extra work and effort, and for things to last, there needs to be managerial buy-in. That is really important to sustain the project. think about your scope and your timelines, be realistic, under promise and over deliver rather than the other way around, and manage expectations so that people don't get disappointed. Everything is not going to change over the day, but we are incrementally moving things forward. That piece about preparation, understand your context, build your trust. Very importantly, put in a robust outcome measures that you can track your progress, and that was something that we didn't do as well, but we hopefully will be moving forward in a better way there. And consider building momentum by doing small scale rapid cycles, to build up that enthusiasm, and have a communication strategy so you let people know of what you've done. And then the final piece that I would say around, if we were doing it again, knowledge has moved forward, and Fliss is going to talk to that about what now is some of the learning. And some of the piece around it is the fact that there's much more of a focus on management of chronic diseases, heart failure, COPD, and so on. And in order to manage chronic diseases successfully, there's an evolving piece of learning that you have to have a whole systems approach. And the Wagner chronic disease model says, for successful chronic disease management, what you need is informed, activated patients and prepared, proactive clinicians. So you need patients that are self-managing and are engaged, but you need clinicians that are prepared, that aren't reactive, that are looking forward to managing chronic disease. And in order to effect change, you need to do all of your actions should cover the community, supportive environments, personal skills of the patients, changing your system of delivery design, providing support to decision makers. And if we were to focus our quality improvement engagement activities a little bit more systematically through that framework, we probably would have more whole systems change and sustainability. So it's still about doing the things, but it's just about having them within a coherent plan. So that brings me to the conclusion. Sorry for running over by a couple of minutes. But really what I suppose I'm saying is that this is a journey. We're starting perhaps sometimes with low levels of capacity, sometimes we're starting with very high levels of capacity, but the really important thing is that change is possible, and that collectively we do it more successfully than individually. So thank you.